Welcome, everyone. It's just a friendly reminder to mute yourself once you connect. We appreciate you being in here. We'll start momentarily. Welcome, everyone. We'll just wait a minute. Thank you for being in here.
It's nice to see we're attracting people from a wide area. Welcome, everyone.
Thank you for the people who are inputting in the comments where they coming from. Yeah, if you like to say where you are, and for the people in the north, we are sorry that you're still experiencing a lot of coldness and snow and all that stuff, but at least it's spring.
Yes. I'm glad it's spring.
I think, Dr. Wise, we can start.
Okay, welcome, everyone. As you come in, please mute yourself so that we can start the presentation. I'm Dr. Deborah Weiss. I'm the co-chair of the Florida Asthma Coalition and the co-chair of the Home Visiting Work Group with my colleague here, Dr. Wanda. We're very pleased today to have Dr. Ramirez from Nova Southeastern University to present on changing the way we look at asthma control, the importance of implementing the AIRQ in practice. The AIRQ is a tool. It stands for the Asthma Impairment and Risk Questionnaire. It can really help in assessment and management of asthma control. And I just want to say one thing before I turn it over to Dr. Wanda, and that is please check out the Florida Asthma Coalition homepage about our upcoming summit, which will be both in person and virtual on June 16th in Fort Myers, Florida. And there is also a call for abstracts and posters. So if you have any recent research that you would like to present, by all means, join us and be a presenter. Okay, thank you. Dr. Wanda, take it away.
Well, good afternoon, everyone. And again, thank you for being in here with us with the Florida Asthma Coalition, the Home Visiting Work Group. I'm very excited about this topic. it's another tool that we can use to help people living with asthma to manage their asthma and also communicate with their primary care provider or their physician who is so you can create a team and get hands-on to that asthma management and control. So we have the honor to have Dr. Nina Ramirez, who is a fellowship trained and board certified adult and pediatric allergist, immunologist, and pediatric pulmonologist, a fellow of the American Academy of Allergy and Asthma and Immunology and the American College of Chest Physicians. Dr. Ramirez is a clinical assistant professor at Nova Southeastern University. Dr. Kiran C. Patel, College of Osteopathic Medicine, a native of New York City. Dr. Ramirez is a proud graduate of the Weill Cornell College of Medicine. She completed her residency in pediatrics at the Mount Sinai Hospital in New York and a pediatric pulmonary fellowship at both Mount Sinai and Children's Hospital National Medical Center in Washington, D.C. In 2000, after 15 years in practice, Dr. Ramirez returned to fellowship training in adult and pediatric allergy and immunology at the University of South Florida, Department of Internal Medicine Division of Allergy Immunology. She joined Asthma and Allergy Associates of Florida as a consultant in 2002. In 2018, Dr. Ramirez became the 69th president of the Florida Allergy and Asthma and Immunology Society. She remains active as a member of its executive board. Dr. Ramirez is a speaker and advisor for several pharmaceutical companies. Her area of interest and expertise is the identification and appropriate use of biologic therapies in individuals with difficult to manage atopic dermatitis, severe uncontrolled asthma, chronic rhinosinusitis, and nasal polyps, eosinophilic esophagitis, and chronic spontaneous urticaria. As an advisor, Dr. Ramirez is involved with initiatives which address the disparities in allergic disease expression and treatment outcomes in Black and Latino population. Her numerous local, state, and national conferences, lectures, and webinars are available upon request. So without further ado, we introduce you to Dr. Nina Ramirez. Thank you.
I want to thank you all for your warm welcome. Dr. Rodriguez, Shelby, Dr. Weiss, and the entire Florida Asthma Coalition, which I now consider family, for the honor of addressing this very important topic. I have been in this space for decades, and I can tell you, together we can become the change we seek, only if we keep our vision clear and change the way that we look at asthma control. I'm going to stop my video as I start the presentation. And we're going to, if you all, Shelby, Deborah, and Monica can come off camera too. Thank you. Today's objectives are to recognize the burden of uncontrolled asthma in the United States and recognize the consequences of patients and clinicians' overestimation of asthma control, SABA utilization, exacerbations, and systemic corticosteroid exposures. We're going to learn how the AIRQ can help identify individuals with uncontrolled asthma and heighten awareness of the need for clinical interventions amongst all healthcare professionals. Severe exacerbations contribute significantly to asthma morbidity. Let's take a look at the burden of severe asthma exacerbations in the United States. In 2020, there were approximately 25.3 million people living with asthma in the US, with an estimated 10.3 million annual asthma exacerbations. Data from the CDC in 2019 showed an estimated 1.8 million annual emergency department visits, resulting in 170,000 annual hospitalizations due to asthma. Additionally, a retrospective study identified that nearly 2/3 of patients with persistent asthma, ages 12 and above, received oral steroids. The burden of uncontrolled asthma is substantial and projected to increase. In this study, projections from 2019 to 2038 among patients aged 15 and older suggest that asthma prevalence is expected to increase. The number of patients with uncontrolled asthma is also expected to rise. And with more than 50% of patients with asthma expected to be uncontrolled, the associated expenditures are anticipated to increase because of increased utilization of hospitals, emergency rooms, urgent care visits, and the like. And just think about the direct expenses related to medications and other treatments. And notably, there are the indirect costs, an additional burden of missed days at work and at school. But why are we having this discussion in the first place? Because asthma exacerbations not only can be inconvenient, they can be life-threatening. And in this very interesting article, towards the end of last year in CHEST, 25,000 to 50,000 patients a year were admitted to an ICU in the United States. The point of this article was to talk about the management of life-threatening asthma. My question is, why are patients arriving to the ICU in the first place? And with life-threatening attacks comes the risk of mortality. Note the number of asthma deaths in 2020. It's increased. And the breakdown amongst adults and, yes, the children. Have you ever witnessed mortality of asthma in a child? During my residency, sadly, I did. And amongst patients who are at greatest risk of prevalence and morbidity, children of color. Taken directly from the Asthma and Allergy Foundation of America and the CDC, on the average, 10 people in the United States die daily from asthma. In 2020, deaths due to asthma rose for the first time in 20 years. Adults are 6 times more likely to die from asthma than children, and females are more likely to die from asthma than males, and male children are as likely as female children. Black people in the United States are nearly 3 times more likely to die from asthma than whites in the United States. And when sex is factored in, it's the Black female that has the highest rate of fatality due to asthma. In 2021, Black females were 3 times more likely to die from asthma than white males. Regardless of the underlying drivers in asthma, whether it's allergic, eosinophilic, or non-allergic or non-eosinophilic, various triggers can instigate a rise in inflammation, which can lead to less than optimally controlled asthma and an exacerbation. Inflammation is variable in its activity, but inflammation is always present. It's always present to some degree. Now, patients can present with any or all of these findings, typically a cough, a wet or dry cough, with harsh bursts throughout the day. They may hear a whistling sound, a wheeze, mainly when they breathe out through narrowed airways. They complain of chest tightness, shortness of breath with activity, or even at rest. The early morning awakening with cough after midnight, I always ask about that occurrence because, again, that's may be a sign of poorly controlled asthma. And they may laugh and cough and exercise and cough as well. And for many, it is like breathing through a straw. As stated in the NHLBI and NAEPP expert panel report from 2007, asthma control consists of 2 domains, represented by symptom impairment and exacerbation risk. As asthma control worsens, the chance of an exacerbation increases. And we learned that from the Tenor study published in 2009. However, the asthma control questionnaires that are recommended by the guidelines to assess adolescents and adults with asthma address the impairment domain only, the ATAQ, ACQ, and the ACT, which was published in 2004. And just think about the exponential growth in our understanding about asthma, along with the development of incredibly effective therapeutics, has been up until and since then. We have come a long way, but we still are not connecting the dots. Prior exacerbations are a strong predictor of future exacerbations. History does repeat itself. Asthma control is often overestimated because the exacerbation history is not always recognized. This is the error of omission. Exacerbations are associated with committing patients to repetitive courses of systemic corticosteroids to address exacerbations, while adding additional burden to an already burdensome disease. I call this the era of commission. Observational data have suggested that standard bursts of systemic steroids may result in a cumulative steroid burden of future health. Significant risks become apparent when crossing the 500 milligram and 1,000 milligram threshold of cumulative lifetime systemic corticosteroid exposure compared to a reference category of more than or less than half a gram, that's 500 milligrams of systemic corticosteroids. Let's take a look at what this actually represents. Here are some of the long-term cumulative risks of developing type 2 diabetes, anxiety, depression, renal impairment, cataracts, pneumonia, and osteoporosis associated with repetitive dosing. And although not highlighted in this particular study, there is concern about development of adrenal insufficiency, natural cortisol production, and an important topic and concern for many parents, the effect of steroids on a growing child. Practitioners have no control over steroids exerting a systemic effects. Once you prescribe them, you cannot direct them to address the airway exclusively. GINA guidelines and the expert panel review in 2007 suggests a 3 to 10 day course of 40 to 60 milligrams a day to treat exacerbations when deemed necessary by the physician. Now, depending upon your training and experience, a typical course might be 20 milligrams a day for 5 days or 200 milligrams. And as you see on the left side of this slide, you're under that 500 milligram threshold. So you see that you still, nonetheless, may not be at risk at that point for type 2 diabetes and depression and anxiety. But for others in training, their first course might be recommended to be 30 milligrams twice a day for 10 days for a total of 600 milligrams. And then you've already crossed that threshold with just one course. And look at the development of these health issues, how they increase. When you cross that threshold, you begin to see more prevalence of diabetes, anxiety, osteoporosis. We are 1.9 times the risk of developing osteoporosis. And just think of the sources of this repetitive action. Look, patients receive prescriptions for steroids from their primary care doctor. They go to their subspecialist, they go to the ER, they go to urgent care, and they self-prescribe with leftover tablets from the last exacerbation. I say it's like squirrels, saving up acorns. And you see that it doesn't take too many steroid bursts to cross the threshold. And while there are long-term consequences to repetitive dosing, there is also the potential for acute adverse events for some. And this study revealed that within 30 days of oral steroid initiation, the incidence of acute adverse events such as sepsis, venous thromboembolism, and fracture approximately doubled. Symptom impairment-based tools like the ACT can result in under-recognition of uncontrolled asthma. Now, based on a cross-sectional analysis from a longitudinal study of over 1,000 patients greater than 12 years of age with physician-diagnosed asthma, 32% of patients who were asked to assess themselves thought that they were completely or well controlled. And when you look back in their history, they had one or more exacerbations in the last year. That doesn't look too well controlled to me. 30% of patients that were assessed by subspecialty clinicians, you're talking allergists and pulmonologists, they assessed patients as being controlled or well controlled. And these individuals, when you look back in their record, had one or more exacerbations in the last year. 29% of patients classified as well controlled by the ACT had one or more exacerbations in the last year. It is obvious we're missing these patients. The AIRQ assesses both risk and impairment. And in this study, only 15% of patients were rated as well controlled by the AIRQ had one or more chart documented exacerbations. It's clear that the AIRQ provides a more accurate and comprehensive assessment of asthma control. Let's look at the ACT, published in 2004. And this is a 5-item tool that assesses patient-reported impairment symptoms and rescue medication use over the past 4 weeks. It uses a Likert scale to score each item on a scale from 1 to 5, with a final total score of more than 20, indicating very well controlled, less than or equal to 16 to 19, not well controlled, and less than or equal to 15, very poorly controlled. So if your score is 19 or less, the patient is reminded that their asthma symptoms may or may not be as well controlled as they could be. And this validated tool has been used for years to assess asthma control in patients 12 and up. And many of you are aware that there's also a validated childhood asthma control test for children 4 to 11. Now, the Asthma Impairment and Risk Questionnaire, the AIRQ, is a set of 10 yes or no questions that is designed to help the patient and healthcare professional talk about their asthma control. The AIRQ is intended to help patients with asthma who are 12 years of age or older. The survey asks questions about their asthma medications, asthma symptoms, and asthma exacerbations. The assessment of their level of asthma control is based on their answers to the AIRQ. The goal is for your asthma to be well controlled. Your chances of having an asthma attack go up when your asthma control worsens. Even patients with asthma considered well controlled can have an exacerbation. The AIRQ is not intended to diagnose asthma, nor is it to be used to assess asthma control in children younger than age 12 just yet, and there is one that's in development. It's not meant to take the place of advice or treatments given to you by your healthcare provider. And you need to tell which treatments you really need to engage with your healthcare team, which asthma treatments might be best for you, because the AIRQ is not intended to do that. And it's not going to collect or store any of your personal information. Let's take a little bit deeper dive into the AIRQ and the questions themselves. Available in English and Spanish, the AIRQ is a composite questionnaire validated for patients aged 12 and above with asthma. There are 10 yes and no impairment and risk items addressing symptoms, activity limitation, sleep, rescue inhaler use with very helpful visual prompts, and patient-centered social activities, exercise, difficulty controlling asthma, and exacerbations. The first 7 items are the impairment items, and they evaluate asthma control status over the past 2 weeks. The last 3 questions are risk items, reviewing the history of systemic steroid use, urgent care, emergency room, unplanned office visits, and overnight hospitalization over the past 12 months. Now, the patient circles their response to each question, and the total yes answers make up the score, and they place that in the box. And then they are assigned to a control category based on their response. Here are the cut points differentiating the 3 levels of asthma control. A 0 to 1 yes response means you're well controlled. 2 to 4, you're not well controlled. And 5 to 10 yes responses, you're very poorly controlled, indicating an increasing risk of an exacerbation. The AIRQ assesses both impairment and risk, and it's been validated to demonstrate 90% sensitivity to identify well-controlled versus not or very poorly controlled asthma, and 96% specificity to identify very poorly controlled versus all others. The AIRQ results, along with information from the office visit and medical history, can be used to assess the patient's level of control and decide a treatment plan that's best suited for that individual. Especially in high volume practices where time is at a premium, the AIRQ can be used prior to or during a clinic visit and foster a healthy dynamic conversation between the patient and healthcare provider. It can be used in clinical practice, and it can serve to heighten awareness of a need for clinical intervention, a change in treatment strategies when necessary, and accelerate the identification of patients in a primary care setting who might benefit from a referral to a subspecialist. But yes, to the subspecialists to reveal patients with unrecognized morbidity. Yes, we missed the mark as well. Now, guidelines have recommended frequent assessment of asthma control to ensure disease stability and reinforcement of adherence to recommendations. The AIRQ has been validated to assess patients at an annual visit with a 12-month exacerbation recall period, but many of our patients require far more frequent monitoring. The follow-up AIRQ alters the exacerbation recall period to 3 months while retaining the same 7 questions that assess impairment using the 2-week recall. The follow-up AIRQ demonstrated construct validity. It's just as valid as the 12-month AIRQ. In summary, despite decades of scientific advancements and guideline updates, the impact of exacerbations on the burden of disease for patients with asthma remains significant. Variable airway inflammation plays a major role in the occurrence of severe exacerbations and their consequences to the additional burden of systemic steroid exposure. Asthma control is in the eye of the beholder. Patients, clinicians, and impairment-based control assessment tools may not appreciate exacerbation risk and the risk of other chronic health conditions associated with systemic steroid exposure. If asthma control is in the eye of the beholder, it's time for us to see more clearly. The AIRQ assesses both domains of asthma control and can help predict the future risk of exacerbations. The AIRQ may complement current guidelines and, when used as a shared decision-making tool, help to uncover hidden morbidity, optimize asthma control, and potentially lower the risk of an exacerbation. I want to thank you all for your time, and I'll welcome any questions at this point in the discussion.
Thank you, Dr. Ramirez. And if you have any questions about the tool, we just posted the link for the website for the tool, so you can go and visit. There's 2 sections, one for healthcare providers and the other one for people with asthma, so they can look and see at this test.
Thank you, Dr. Ramirez. I just wanted to add that our keynote speaker at last year's summit was Dr. Buckstein, who's been very involved in shared decision-making. And this year we decided to make the entire summit have the theme of shared decision-making. And I wonder, Dr. Ramirez, if you want to amplify a little bit on how important it is to asthma control.
We, especially the way that medicine is currently practiced, and I've seen the change, the interface with the computer screen, and we all have shared in the horrors of the pandemic and necessity for telehealth. But there's nothing like that face-to-face intervention or that opportunity to speak with your healthcare team, because those nuances can be picked up insofar as the degree or lack of asthma control. And these questions really help to prompt and solidify this conversation that has to be had, rather than just kind of quickly filling out, which has happened, just the AIRQ and this is your score, but not really taking a deep dive into the implications of even with a score of more than 20. Because when you look back in patients that were considered well-controlled, these patients weren't that well-controlled at all, especially these tools that are only looking at a 4-week interval versus a 12-month interval. There is lots that's missed. And so I think that this particular tool allows us to engage in conversations that are going to be more meaningful and have a greater impact in selecting the personalized approach to that individual and recognize what's being missed, because there are clearly patients that are being missed. How can you have 25,000 to 50,000 patients a year winding up in the ICU with an exacerbation? And we have dual controller inhalers, we have triple controllers, we have biologics, and still this is occurring. Still the mortality is going up. So there is clearly a great divide. I think the AIRQ can help begin to bridge the divide by amplifying a conversation that needs to be had.
Thank you, Dr. Ramirez. You know, my doctoral and postdoc research was in asthma management on college campuses, and I had a mixed method instrument, but one thing that came out is that there's a lot of misperception among college students about asthma. They think they have outgrown it. They have flare-ups and don't recognize it as such and go and self-medicate or get cold medications or other things. So I think understanding over a long term, not just, as you said, a one-time event or short-term 4 weeks, is so important. And it's really important to destigmatize asthma too. I think adolescents and young adults don't want to admit that they have it. Some students were just toughing it out or borrowing others' inhalers, you know, as needed. So how can we do that? Do you have any tips for adolescents and young people to take better charge of their asthma and not be afraid to do the steps they need to have better management?
Well, I believe that your coalition is a great start from the grassroots level to allow patients to understand better. But it's the primary care team and subspecialists that have to understand better. We are guilty of using euphemisms to describe what inevitably is asthma. And there's not a day that passes when I have adults coming in, oh, the doctor just says I have bronchitis. Well, you know, after I hear the story and the circumstances and in and out of the hospital and they get better with steroids and it's back again, I'm saying, no, I think that this turnstile of events is asthma. And they seem shocked and surprised, and they've been carrying this misdiagnosis for years. Parents too are afraid of the word asthma. And what I try to impress upon them is the fear of this, again, this turnstile approach to oral steroid use, systemic steroid use over and over again. And yes, the child gets better, but only to return again. There is a better way. So we have to recognize asthma for what it is and get away from using these euphemisms, this wheezy bronchitis, this bronchiolitis, this twitchy, you know, I describe it as a twitchy airway, but it's part of the pathophysiology. But I am very upfront with patients and say, this is asthma. Now, there are many different types of asthma. And one of the key issues that we've recognized more recently is that inflammation is persistent. It just doesn't go away. We've been symptom-based in terms of our recommendations with the STEP guidelines. So for example, I say you cough once, you puff twice, you cough 3 times, you puff more. This is a problem because patients are under the assumption that once I have no symptoms, I don't need to treat my asthma anymore. And this even happens with patients that I place on a biologic. So mind you, I see some very severe patients with asthma, and I implore upon them, I said, please, you have to continue to take your controller inhaler because there are other aspects of asthma that are not being controlled by the biologic. And I'm very glad that you're feeling terrific with your injection, but this is not the only part of the story. So I think our recognition that asthma is variable. Asthma is persistent. Asthma can affect the well-controlled. Asthma can become a significant problem, a significant exacerbation, even in someone who is characterized as mild or intermittent. You're persistent. You have persistent airway inflammation that needs to be addressed. And I'm involved with discussion groups about this issue, and how do we project this understanding onto patients, and how do we connect the medications to addressing this persistent asthma? And there's still opinions that are not coalesced as such, but we're getting closer to have more unified recommendations. But again, the big take-home message is that it's asthma. For the adolescent, I always ask about smoking, and I always ask about vaping. They have a disconnect that vaping doesn't count. Oh, vaping counts. In fact, to the degree that I have given presentations and I've shown my audience case reports of vaping lung injury. It's the e-cigarette vaping acute lung injury called EVALI, E-V-A-L-I, that mimicked respiratory failure from COVID. And this person did not have COVID. They had the e-cigarette acute lung injury, complete with honeycombing of the lungs, and they spent time on a ventilator. So this is how severe this can become. I've had patients with asthma start vaping because they thought they could vape, and then their asthma control is lost. So there's a whole host of triggers. Getting that cat, if you're cat allergic, that you're insisting you have to, you know, there's some things that you think defy logic, but you have to have that person-to-person discussion and convince them as best as you're able that there is a better way and that it puts them at unnecessary risk.
Thank you, Dr. Ramirez. There's a question in the comments. It says, are you able to speak at all about weather / climate affecting asthma exacerbation?
Yes, well, yes, it does. For some individuals, cold air can trigger an attack, and others, they feel better in colder air. Others find the humidity or heat triggering. So it's variable in the individual. We used to think that you'd move to certain areas of the country and escape allergy. Well, patients that have brought their houseplants and their pets to those areas, they just had all those allergenic triggers join them. And there may be areas, of course, with perhaps less of a seasonal variation. But as you know, our climate is changing and maybe actually extending our seasonal, the seasonal triggers that were once shorter in duration, becoming longer in duration. So yes, climate, pollutants definitely can have a detrimental effect on some individuals with asthma.
Yes, and to add something, I grew up in Puerto Rico having asthma, and I remember vividly my pediatrician. If you met him, Dr. Nina, Dr. Pedro Mayol. He was my pediatrician, and he passed away just recently. But he will say, "Yeah, you need to move to Arizona.
Right.
Maybe that will help Wanda with her asthma." And now we know it doesn't matter. You know, we have asthma. I have asthma, and I know my triggers, and it doesn't matter where I live. If I don't control my triggers, don't take my medications, and also, you know, medication technique. It will be. I mean, it doesn't matter where I go to live. And also I now because of what I'm doing right now as the asthma program manager, I am more aware of my environment. So I'm always looking at the air quality in my area, and I can check if the ozone level is high or there's a PM 2.5 particles floating all over the place. And so I just kind of look, what if I go outside, is that going to trigger my asthma? Even though it's controlled, but there's some things that you just, need to do. We need to make sure also that here in Florida, for example, when we have these thunderstorms, we understand now that there's something called thunderstorm asthma that make these particles, break them in little, even smaller particles that you can breathe and, get triggered. So I think one important thing, other than taking your medications, have a beautiful communication with your healthcare provider. And it's also to own how to understand that the environment, indoor and outdoor and even occupational, where you work, can trigger your asthma. So just get to know everything that might trigger your asthma. So just check your environment. Let's see. I have Katie that is asking, what is being done to identify and treat early stage sleep disorder, breathing restrictive or obstructive, causing nasal disease within the asthmatic community? So I think it's Katie wants to check breathing problems like sleep apnea and maybe nasal polyps or rhinitis, which is one of the triggers for asthma.
Well, insofar as chronic rhinosinusitis with polyps, nasal polyps, about 60% of patients will also have coexisting asthma. And these individuals sometimes have the worst asthma. So it's very important to have a complete examination and questioning about the sense of smell, whether it's complete loss or partial loss, but nonetheless, that's not normal. And you have to have an examination to demonstrate whether you do or do not have nasal polyps, perhaps aspirin allergy as well. And so these are issues that can coexist together, as too can obstructive sleep apnea. So sleep disturbances at night, I'll see children with very large tonsils and potentially adenoids. And they have that kind of look to them and the mouth breathing. And I ask parents about noisy breathing at night. And if they actually witness any type of hypopnea or apnea, to visually record the sounds, and also, as best as they're able, a visual to bring back and show me. And they're very important. The parents are very important in helping to diagnose that. But if the pediatrician is not asking those questions, that's not going to get done. Likewise, too, with adults, I'll see adults of all builds, of all BMIs. Usually in the higher BMI category, structurally, I will, again, I can appreciate certain signs in their physical examination, like the Mallampati score, when I'm looking in the oral pharynx, and I cannot see clearly back in the throat because the tongue is literally obstructing my view. And these patients are a great risk for obstructive apnea. And I'll ask them questions like, do you feel you snore at night? And their people are in denial. Or if the wife is with them, he says, yes, I have to wake him up because the guy stops snoring. He just stops breathing. I go, well, we've got to get a sleep study, because this is associated with high blood pressure. This is associated with cardiovascular risks. This is associated with gastroesophageal reflux disease. So there are a lot of associations in patients with coexisting asthma. You mentioned allergic rhinitis, of course, but if you looked at asthma as the center of the universe, there's all these other influences and all these other comorbid conditions that these boxes have to be checked, because if these issues are not addressed, asthma control will not be optimal.
Thank you. Another question that came is from Francis. I love that name. I have a daughter named Francis. I am a tobacco and nicotine treatment specialist. Just to confirm, EVALI is associated with symptoms similar to COVID-19 and can contribute to severe lung injury. Any other thoughts on this to share?
Well, as I mentioned, I floored the residents during the our Florida Allergy, Asthma, and Immunology Society meeting last year when I was asked to address the residents in training about asthma and COPD and asthma COPD overlap. And I wanted to share with them about the dangers of vaping and the necessity to ask the question, because if you don't ask, you won't tell. And our adolescents are in denial that this is equivalent to cigarette smoking. So yes, this can mimic other lung diseases, but have end-stage consequences. End-stage consequences, including mortality, including a need for lung transplantation. So this is out there in the public domain in the literature. And perhaps another time we can focus on a vaping lung injury discussion. But these are things that definitely can coexist and contribute to the morbidity of poorly controlled asthma.
Yes, it just we had a previous lunch and learn about vaping, and it's just one of the things that's still hanging in there is just like a few years ago when the e-cigarette started to appear, some medical professionals or healthcare providers were saying, okay, the e-cigarettes might help you quit tobacco use, but now that we have a lot of information about the vaping and e-cigarettes and the lack of regulations on that, we're just seeing many lung injuries increase and also exacerbation. And it's not only that, we don't talk a lot about smoking anything else. And I'm always convinced that nothing but air and asthma medication should be inhaled into your lungs. It doesn't matter. It just, it's still injury to your lungs when you add any type of smoke into your system. So, and it's not only the smoke, it's just all the not known ingredients and carcinogens and different chemicals that goes directly into your lungs. So definitely we need to get that idea that e-cigarettes are helpful, but they're never helpful for any person that has any chronic lung disease, asthmatics and people with emphysema and stuff like that. So something that I just want to go back, and it's just that like you said, Dr. Ramirez, is just so the myth that we have and the euphemisms that we have about asthma, and one of them, most people believe that the myth that the kid will outgrow asthma, but then on the other side of the coin, most people don't believe that they can actually be diagnosed with asthma being adults. And it's just a very resistant thought, say, but I grew up fine. I never had anything. So how do you tell this newly diagnosed adults with asthma, how do you present that to them?
Well, often, with a good history, you may be clued into signals earlier on in life. Now, not every patient with asthma, again, is going to have this persistent, this relentless course. There are patients that seem to go into a degree of clinical remission for years and years. And often these are patients that are not allergic and that are not smoking and are, again, basically their genetic predisposition is one towards this clinical remission, we've learned a lot of different phenotypes and endotypes of asthma through different studies like the Severe Asthma Research Program, and also investigators looking at sputum analyses in different patients with different kinds of asthma, and have come to understand that it's really the asthmas in plural. There's more than one. And so I emphasize to adults who come in with this so-called de novo experience of recurring shortness of breath, cough, wheeze, chest tightness, after a number of possibilities are eliminated, because again, this is going to be based on the history and elimination of other potential diagnoses. Once I'm certain that this is asthma, I say to them, I say, when you look back in the history, if this has been happening, if every time you've gotten a cold, it's gone to your chest, or the doctor's giving you prednisone or steroids and you feel better, or the cough with a cold lasts for weeks and weeks, maybe months, these are signs of asthma. And you may not have been diagnosed as such, but I want you to understand that there are treatment options available. So this doesn't have to become, I keep referencing the turnstile as a New Yorker and the old subway turnstiles going around and around and around. This madness can end. And so once I present it to them in a way that for many of them, it's not their first time experiencing this, that unfortunately the word has not been used. And perhaps they've had experience with other family members or friends that may have had a really poor outcome associated with asthma, and it's fear. It's an understandable fear. Now look, COVID, it's very interesting. COVID as a virus, but there are other viruses too, can ignite the innate immune system and kind of provide a wake-up call to the airway. And I have patients presenting in later years after COVID with a chronic cough that turns out to be asthma, because they have had this dormant situation for years, only to have had this inciting, this instigation of the epithelium and the wake up from this, and the innate immune system in response to a viral trigger. It is quite remarkable. And these patients I'll treat with with the right medications for asthma. So it's a healthy discussion, Dr. Rodriguez. It's a discussion that we have to focus our attention on the history. History repeats itself. And these are the stories that I relate to patients, and so that they can feel that they're not the only one, that they have now joined an exclusive club of people who can find a remedy to end the madness.
That's awesome. Thank you. Another question came in is from Carol. It says, I have a question regarding the link between stress and asthma. Why does stress triggers asthma?
Well, there may be some endogenous hormonal issues with stress. I don't think we know enough about that, but our mast cells have these natural endorphin receptors, and with stress, your cortisol levels go up, your natural morphine levels go up, and this may cause signaling to certain cells that create this downstream effect in terms of airway constriction and bronchospasm. Also, too, there are individuals that have a very high stress level who may have other issues that are mimicking asthma, like vocal cord dysfunction. That when they get stressed, they have this difficulty, this breathing in, and they point to their upper airway. And I'll ask the patients again and say, point to me, where do you feel is where you feel that your air is most inhibited? And they point to up here and maybe the upper chest, and I go, okay, and I'll do a lung function study on them and a spirometry, this flow volume loop, and I might see actual flattening or attenuation of the inspiratory portion of the flow volume loop that's supposed to be like a loop and not a flattening of where the vocal cords adduct come together instead of opening upon inspiration. So that's where they feel that as I say, their wind is cut because their vocal cords are coming together. So that's what stress can induce. Stress can induce a mimic of asthma. And of course, vocal cord dysfunction can coexist with asthma. And so it makes a difficult situation perhaps more difficult, but not impossible.
Yes, sorry, Deborah. I just wanted to kind of add, if you dissect when you're stressed, in the sense, what's going on and your breathing pattern changes. Even, even if you're laughing, crying, afraid, anxious. So we know about the twitchy airways, that we have. So that can create a chain reaction, a pattern of the breathing pattern into an asthma exacerbation. So obviously at that moment we don't kind of figure out what's going on, but if you do something, what's going on anatomically when you're having when you're laughing or crying or screaming or something like that, that's one of the ways I think that can trigger an asthma exacerbation.
Yeah, I just wanted to add that the GAS syndrome, if you have chronic stress, eventually leads to exhaustion and it depletes the immune system. So any underlying conditions are going to be exacerbated, including asthma. So if you have an underlying condition, it's all more important to practice regular stress management. I just wanted to thank you, Dr. Ramirez. This was wonderful. And I wanted to learn more about the E-Valley because the research base on vaping is still relatively new. There are no really long-term studies that I know of. And I think this is a topic we might consider adding to our summit. And that is my segue to Shelby to please put in the chat or on the screen the flyers so you can all register. If you'd like to hear more, Dr. Ramirez and our wonderful speakers on June 16th, please register for the summit. There are about 200 spots in person, and then we also are going to have it online, and it will be in Fort Myers. Thank you so much, everybody, for attending.
Thank you for having me.
Yes, on that piggyback, again, thank you, Dr. Nina. As always, it's just been a pleasure to listen to you and your well of knowledge on asthma. And for the audience, please join us for the free 2023 Florida Asthma Coalition Summit in Fort Myers in June 16th. We have a packed agenda for with wonderful speakers, including our own Dr. Nina Ramirez. And so if you have more information, please visit our website, and we'll also accepting posters and abstracts for our summit. So if you have something that you want to share about asthma, please follow the link. It's on the chat. And again, thank you everybody for your time and your presence in here. And Shelby, if you want to say something also.
Just to say thank you again, Dr. Ramirez. We're so excited to have you in person in June. The registration link has been dropped in the chat by Caitlin. So if you all are interested in attending the summit, either in person or virtually, we have registration for both. We would highly recommend getting a jump on that now, since there are limited seats for the in-person session. Additionally, Caitlin has dropped the poster submission instructions in the chat for you all to review. So thank you all again for your time, and we're so fortunate that you joined us this afternoon.
I just want to add one thing. I am chairing the poster committee, the abstract committee. So if you have any questions, feel free to email me, and we welcome your research and want to find out what's going on in the field where you are. So thank you, everyone. Thank you, Dr. Ramirez.
You're welcome. Bye.
Okay, everyone. Again, thank you so much for your attendance.
Thank you.
and we'll see you next time.